Good morning and welcome to our NHS West Yorkshire Integrated Care Board meeting. We're here in Wakefield today, and this is our fourth full public meeting out and about in our communities that we serve, and we're delighted to be here today. We have colleagues around the table who are representing the breadth of health and care from all our 5 places, as well as the variety of services and sectors that we work with within our partnership. I'm Cathy Elliott. I am Chair of NHS West Yorkshire Integrated Care Board, ICB, and I'm also Deputy Chair of our Health and Care Partnership. And for anyone watching online, live streamed or recorded, thank you very much for your interest in our work. We also have some public questions which we'll go through in a moment, and I'm grateful to members of the public who've been taking the time to go through our documents and share their interests and concerns with us, and we'll respond to those later. So, as you know, we are part of a system, and we're one of 42 systems in England. And just a reminder for colleagues, but hopefully helpful for people that might be watching online, we have 4 purposes as an integrated care system around improving outcomes in population health and healthcare, to tackle inequalities in outcomes and experiences of healthcare, to enhance our productivity and value for money, and to support broader social and economic development. And what I hope board members can see, colleagues across health and care, as well as members of the public, that our documents and our discussions today reflect all 4 of those purposes. And that includes looking at our strategy that was signed off at our partnership meeting on the 7th of March in Leeds, and that all that information is available online. Again, for colleagues across health and care and members of the public, all the documents for our meeting today are available online. They are individually there for you to download by agenda items so that you can look at whatever areas of interest you have. I appreciate in the nature of public sector and NHS, some of them are quite long, and we continue to take on feedback on how we can improve the accessibility of documents, but also there's a balance there around transparency and openness, particularly as you can see we've openly shared information around contracting for commissioning that we're going to take on from April. So there's the introduction. Again, I just want to thank everyone for turning up today, people who've taken the time to take an interest in the meeting, but also more broadly, and I'm sure Rob will talk later about this, more about thanking everybody who's working in health and care at this time to make sure that we've got safe quality services. It's an incredibly pressured time. We appreciate that, and everyone's efforts and team efforts as we work across our partnership, which is a true partnership, are incredibly appreciated. So we're going to move now on to some standard parts of our agenda. We have apologies today. Laura, will you just talk through the apologies and any deputies we have?
Thank you. We've had apologies today from Aranangsu Chatterjee, Anthony Keeley, and we will be having a deputy from Deborah Taylor-Tate later in the meeting. Apologies from Tom Reardon, Karen Jackson, Councillor Tim Swift, and we have a couple of colleagues who will be joining us late, Robin Tuddenham and Sarah Munro, and we also have apologies from Majid Hussain.
Great, thank you very much. And also, just for members of the public and anyone watching online to know, we will be running an engagement session in the middle of our meeting today, and our focus on session this time is on the sustainability of the voluntary community and social enterprise sector. We're grateful to Kim Shuttler, who is our sector advocate on the board, for the time and effort she has undertaken with a number of colleagues and people across all 5 places in preparing the document for today. So we will take a number of items, then we'll pause and have an engagement session with voluntary sector leaders, and then come back to the rest of our meeting. And colleagues around the table, I'm grateful to you for sharing your very open feedback on how we can improve these meetings. This is only our 4th full one in public. We're learning all the time, and I hope you can see we're trying a different format this time to see whether it works. And please be honest with us whether it did or not, and what we can improve for the future. So the next item is around declarations of interest. Does anyone have any conflicts of interest in relation to today's agenda? No? Okay. Thank you. And also what we can note is we've got a register of interest, our matrix of interest, which is available online. And I just wanted to make reference to that. That's, again, a part of us being open and transparent. But also I know we had a question from a member of the public for our partnership board back on the 7th of March who was asking about this, and that's available online there. Okay, so we'll move on to our next item, which is item 3, our minutes, action log and matters arising. Colleagues, do you feel that document is a fair reflection of our meeting back in January together in Leeds? Are there any typos or corrections? Becky, would you introduce yourself?
Becky Malby, non-executive member. Just a couple of things, Kathy, and that's on the action. So on page 10, just under the actions, we've got that the places are going to be looking at the excess deaths, but it's also the quality committee, and it just needs to be in the action that it's the quality committee as well. And secondly, page 13 on item 52, it doesn't have in the action that we've got the task group looking at our own integrated dashboard. I think that should be there too. Thanks very much.
Okay, so we'll take those corrections to the action log, and we will go through that in a minute with Laura. Colleagues, with those amendments to the action log, are people happy to sign off the minutes of the last meeting? Okay, thank you. And thanks to governance colleagues working on that. I know it's always a point of learning in all the documentation we're improving, wishing to improve upon. Okay, so then we have the action log. Laura, will you just highlight some key points for us or call in colleagues?
Thank you. I will do. The first two open actions that we have both relate to how we ensure that people are at the heart of our decision making. The first open action, which dates back to September, we proposed that we would meet with those individuals who met with us. We met with some young people and carers for a listening session. We said we would meet with them again after 6 months. I don't know if you wanted to provide an update around that, Kathy.
Yes, and I think this is something we can bring in. It's something that's in my chair's report today, as well as I know we're going to invite Hannah Davis from Health Watch to talk at our next meeting about people at the heart of decision making. We do need to make a commitment to re-engage with people when we've made promises around policy and ways of working and improvement to services, and through our West Yorkshire Voice, which is what I've outlined in my board report today, is a way in which that we can hopefully embrace a variety of people across our communities, including young people, but I feel we need to make a commitment back particularly to the Young Citizens Forum as well to meet with them.
Thank you. And just linked to that, the second open action, action 9, just flagging that we will be discussing how we use the feedback at the April development session and also at the next board meeting. If I can just take members of the board down to the next open action, which is action 35, which came from the Chief Executive's report last time, and Becky mentioned around the excess deaths. I don't think that's an action we'd be in a position to close straight away, but I didn't know if anyone wanted to give an update around any discussions that have happened at place committees or through quality committee.
Do we want to, Rob or Bev or James, do you want to perhaps share some views? We unfortunately don't have our chair of our quality committee today due to sickness. Rob.
I think it might be worth asking Rachel for a view. We've got a substantial amount of work that's required to be done. If you remember at the last board meeting, there was a conversation about speculation in the media of the cause of excess deaths. And we had an update that said it's too early to say at this point. And there'll be multifactorial complex reasons why, and we need to take some time to look at those. So Rachel and the Director of Public Health may have a view.
Rachel, would you introduce yourself?
Yeah, thank you. My name's Rachel Spencer-Henschel. I'm the Director of Public Health for Kirklees and the representative for the West Yorkshire DCPH on this board. So yes, so in terms of excess deaths, it's always one of those things that at a population level, by the time we actually need the answer, it's probably too late in some cases to take some action forward. One of the things that has strongly come out recently is the lack of opportunities to essentially intervene in terms of secondary prevention. So quite a lot of the things that happened during COVID, which led to people missing out on things like basic health checks, and potentially some of those lifestyle behaviours got worse during that period of time. What's happened is the impact of that, and for a consistent period of time of that not being checked and managed, means that we're seeing some of those through cardiovascular incidents in hospitals, and they've become more serious than they would otherwise have been had those conditions been managed. And actually, one of the pieces of work that we're going to be taking forward is how we can see things like NHS health checks and other interventions as almost like it's not just about the initial condition that somebody's diagnosed with that's picked up through a check, like, for example, hypertension. It's then how you make sure that that's a preventative intervention to make sure that doesn't lead to multiple comorbidities like diabetes or other things like that. So essentially, I think the real strong message for us as an ICB is how we support primary care to be intervening earlier around some of these potential comorbidities, how we use the public health targeted work on NHS health checks to pick up those people who are less likely to go and get NHS health checks and actually be in contact with mainstream services. and equally how we can use hospital admissions to take people back out into the community and do some of that lifestyle interventions, such as, you know, physical activity, stopping smoking, etc. So I think that's probably, although obviously I couldn't sit here and say I know exactly why we've got the excess death numbers we have, it's quite obvious that the impact of COVID and lockdown and lack of access to services and potentially some of those interventions means that we have an opportunity to pick some of that up. But I would suggest that we need to segment our population and look at those that are more likely to be in that space with those multiple morbidities, because actually the things that contribute to that and the impact of those will always be things like inequalities and some of those wider determinants of health that as a board obviously we're committed to looking at as well.
Thank you, Rachel. James, do you want to come in? And then Becky, would you introduce yourself?
Hi, my name is James Thomas. I'm the Medical Director for the West Yorkshire ICB. So just to kind of follow on from that, from what Rachel has just said there, from West Yorkshire, in the past, we have done a lot of work with Healthy Hearts. We recognise in terms of what Rachel's just said in terms of the impact with our cardiovascular. So we are, West Yorkshire is kind of revisiting and looking at how we can embark more on and build on the work that we've done with Healthy Hearts, looking at the work with prevention, working with our local authorities, again, as Rachel's mentioned, in terms of smoking cessation, also looking at kind of weight management and lifestyle changes there. So through our places, through across West Yorkshire, working with Healthy Hearts, the work we did there, we're emphasising that and hopefully kind of building on what was a successful campaign before.
Thank you. Becky, do you want to come back in?
Just to remind ourselves that when we were talking about this, it was a range of excess deaths. There's excess deaths related to COVID, and that includes all of the issues that you just said, Rachel. There's excess deaths in relation to waiting, and we know that's borne unequally. So a better understanding of the impact of that across and what that means for our work on inequalities. So I think I'm still not clear on that. And the third thing was excess deaths or excess deaths in this paper was around waiting because of the ambulance issues. So it was people who are waiting in ambulances or waiting for ambulances or waiting in A&E waiting to go in. And that was, of course, what was in the media, and that spurned this issue in the first place. So I think we've got 3 categories of excess deaths, Rachel. And I think knowing what's our process for understanding those 3 would be really helpful.
Rich, do you want to come back and then we'll move on?
Yeah, just to wholeheartedly agree with Becky on that one. And I think probably it's easy to talk about population level health, isn't it, in terms of what we can do from that perspective. I guess that was why the board asked to look at it both in the quality committee and in the place leads, because actually there's something about that real-time understanding of the impact of those sort of metrics in terms of ambulances, etc., that will help us understand what those actual deaths are on a local basis. But I do think what James has said in terms of what we can do to try and prevent that happening again in terms of some of the bits we can control outside of the acute system is really important, because that will obviously have an impact in years to come, whereas there's certainly a piece of work I would agree about how you look at what are the inequalities within those waiting times and how has that contributed more practically to excess deaths.
Okay, so I think let's keep a watching brief on this. There's something for the Quality Committee at ICB at West Yorkshire level to look at, and I think that segmentation, Becky, is really helpful for you as a member of that committee to work with Majid, and who is chair of the committee on the non-exec side, and James and Bev as medical director and director of nursing. And then place leads, I leave it with you on how you may want to further and develop your work on this, but there's something about greater insight on this, oversight and scrutiny as well. Rob, do you want to come back in?
Yeah, I wanted us to be clear and a bit more precise, I think, in our use of language, so that we don't end up in the wrong place here. So I think we know that excess deaths around the publications that we see from ONS and others, describe how many people have died over and above long-term trends. And we can look at what the causes of that are, and I think we've talked about how that's something for the Quality Committee and the places. I think we've talked about, is waiting causing harm? And there's work that goes on in all of our organisations to consider what's going on the waiting list, see who's waiting, and to make sure that harm is minimised. So I think we should seek some reassurance on that and some assurance on that, because I think that is what happens. And we have some specific work for some specific people and groups in some institutions to look at that further. So we've talked, Brendan's here, you know, his trust prioritises people with learning disability on the waiting list because of the potential harm for people waiting with a learning disability. And then I think people who, if there are incidents which lead to death because of waiting for ambulances, that's an incident. I don't think that's an excess death. That's a safety concern. And I think there's a public question about that later. Yeah. And in my report, in the last public meeting, I talked about the increase in incidents. So I think we need to recognise that there should be interventions around incidents, there should be work around waiting, and there should be work around population. And there's work on all three. So I wouldn't want us to feel that somehow there wasn't active interventions, in all those spaces at this point.
Yeah. That's great. Thank you for the clarification. And also, we know that there is great work going on, but it's a point, and non-execs are drawing out key points, aren't they? And I think we can bring that in through to committee work, but be guided by the experts around the table here and in places. Okay, thank you. That's the action log completed. Thank you, Laura, for that. We're going to move on to public questions. And as I said earlier, I'm really grateful to members of the public who've taken the time to ask questions. We really welcome them. And for those of you who don't know, you can submit a question in relation to the agenda of a meeting 24 hours before the meeting takes place. And we have a number today. Due to the number we have, we will read them if they are shorter, or we'll give a summary if they are longer. But as we always do, we will publish the questions in full on our website, and we will provide a written response to the person who's asked the question, as well as putting the written response on our website as well for openness and transparency. So we have our first question from Dean Davidson on digital records. Laura, you're going to read this out for us, and then I know we've got a colleague who's going to respond.
Thank you. Yes, so the first question is, the long-term plan stated that by 2023-24, all patients in England will be able to access their digital records. What are the West Yorkshire plans to ensure patients have access to their own electronic care records through a single platform, instead of each care provider organisation setting up a separate patient portal solution?
Thank you. James.
Yeah, no, thank you. And thank you, Mr. Davison, for that question. So I'm accountable on the board for the digital, and really as part of our work in developing our West Yorkshire digital strategy, we developed a strategic framework for organisations when they're procuring kind of public-facing apps there. But we also took a strategic decision that we wouldn't enforce that every organisation had to utilise a single product there, but because of the current architectural kind of arrangements we have across West Yorkshire in terms of digital there. So it was felt, though, that with that framework there should be some standardisation to ensure consistency from a public perspective there, and so that's hence we brought in the framework within our digital strategy there. So the guidelines for that framework to ensure that the NHS app, which is our kind of public-facing entry into the NHS digitally there, that all apps, when we go through a procurement, that all our apps that are public-facing should integrate with that, both from across West Yorkshire, but also wider, because we have a regional share code record as well there. So, so organisations are progressing with the developments in line with their own maturity of digital, but we have that framework there which sits within our West Yorkshire digital strategy.
Thank you, James. And what we could do in responding online is we can include the digital strategy. And I remember one of your previous reports, Rob, one of the appendices talked about the progress with digital care records as well, so we can include that. Thank you. Our next question is from Chris Hyde in relation to governance arrangements. Laura.
Thank you. I'll read out a summary of the question and then I'll also provide the response. In summary, my question is about the statement of ownership of West Yorkshire ICS in the West Yorkshire ICB VCSE Memorandum of Understanding as follows. The West Yorkshire Partnership, i.e. Integrated Care System, belongs to its citizens and to commissioners and providers, councils and the NHS. Please will the West Yorkshire ICB state the legal chapter and verse that assigns ownership of West Yorkshire ICS. Thus, I thought the statutory bodies that make up the ICS are owned by the government and the third sector organisations are owned by their trustees. The statutory NHS organisation and council members of the West Yorkshire ICS Health and Care Partnership are listed in the Constitution. The Constitution splits them into partner members and ordinary members. Is there any legal difference between partner and ordinary members of West Yorkshire ICB? And then, thank you for the question. The Integrated Care System, or ICS, is not a statutory organisation. It is a partnership that is made up of multiple organisations, all of whom have their own statutory and legal frameworks. The statements highlighted in the question relate to our ethos as a partnership based on collaboration. The ICB itself is a statutory organisation established under the Health and Care Act and our constitution approved by NHS England. As explained in our constitution, the term ordinary members is used to refer to other members of the board apart from the chair and chief executive. Partner members are a type of ordinary member who bring knowledge and a perspective from their sectors. There is no legal difference.
Thank you. And we can include the governance, a link to the governance section, which we are really pleased that we put our whole governance handbook out there online as well for further information. Our next question is from Jenny Shepherd in relation to Yorkshire Ambulance Services and our work together as a partnership. Rob, are you going to... Laura is going to give a summary first, and then if we could hand over to you. Oh, sorry. Should we do this one and then... Sorry. I have just jumped ahead. Laura, would you give the summary of Jenny Shepherd's question, and then Rob is going to respond. Thank you.
Thank you, I will. This is quite lengthy and we will put it in full onto the website. So in summary, the questions relate to a delayed YAS response to 999 calls as follows. YAS reported to its board in February 2023 that having been at REAP level 4 between the 22nd of November to the 23rd of January, serious incidents and moderate harm, largely from delayed response, continue to be reported, and investigations are underway using serious incident reports or after action reviews. This statement contrasts with the West Yorkshire ICB Chief Executive's report that states, particularly on ambulance response times and urgent care, West Yorkshire ICB has maintained good and effective management of the situation. The winter performance report seems not to mention serious incidents and harm from delayed ambulance response. They do follow 9 questions, which I won't read out all of them, but just to give a summary of the main points within those. They relate to coroner's requests and the causes of death, patient harm and deaths, YAS serious incident investigations, patient safety incident reports made by GPs and or other non-YAS clinicians, GPs in the Colne Valley, process for non-YAS clinicians to make serious incident reports about delayed ambulance response to 999 calls, and finally what process we have as an ICB for YAS to inform place committees about serious incident reports and investigations, including primary care, commissioning committees and local medical committees. Thank you.
Rob.
Yeah, thanks, Jenny, for the question. I'll chunk this up into 3 parts, and I'll start, and then I'll bring in Bev, and then I'll bring in Brendan, who's been doing some work on the GP element. So I'll start by saying that the delays in ambulance services cause harm, and those harms are measured through the ambulance service and reported through their board, but they're also a feature of a meeting that we have each week with the ambulance service around pressures in the system and what we can do to intervene and improve the situation, because ambulance response is driven by a number of factors, some of which are outside the ambulance service's control. For example, people have seen in the media reports of ambulances waiting outside hospitals and therefore unable to get back on the road. So in those meetings, we talk about how we're improving staffing in the ambulance service, response times, the IT, the flow around hospitals and other mechanisms, and we have a specific focus on incidents. The report, the question from Jenny, I'd like to say, in my last board report, I talked about the increase in incidents in the ambulance service and the need to focus on safety in a way which is entirely consistent with the ambulance service board reports. In this report, I talked about good and effective management of the situation and situations that we've found ourselves in over the winter. And that's in relation to emergency planning and preparedness and preparing for strikes and the pressures that we've been under in the whole system during that period. It's not a statement that suggests there's been no potential harm. During the period, we've had daily meetings with the ambulance service and across the system at specific times. In preparation for strike action, our acute hospitals have prioritised decision-making at the front door to ensure a quick turnaround, and there have been a range of plans and interventions that have made sure that we had the best approach that we possibly could under the circumstances. As I also say in my report, this has probably been the worst winter that we've dealt with in my experience, certainly in the NHS. That means that there will have been harms, and we will need to address those harms and any learning from them with individuals, with organisations and in the system. And I'll let Bev talk about that in a moment. We've also had requests from GPs to improve the way in which general practitioners can relate to our acute hospitals in crisis. And I'll let Brendan talk about some of the work we've been doing with local GPs to try and improve those services. So Bev, I don't know if you want to talk about the Quality Committee and incident reporting and how that works.
Thank you. My name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB. So in terms of oversight and assurance, we've got a number of committees that get all of the detail, actually, individual incidents, themes, etc. But more importantly, probably, is the learning and the quality improvement as a result of the incidents. So, as Rob's just mentioned, we have a weekly executive tactical group that has representatives from each area of the region, not just the ICB. That's chaired by Rob, and as he said, we go into some detail around incidents and themes from that. Locally in West Yorkshire, we've got the System Quality Group, which is chaired by myself, and every part of the system partners are represented on that. And we have Yaz as a standing agenda item to go through some of the details, and as I've said, in particular, importantly, the learning and the quality improvement. We've recently, as a result of the increase in incidents and as the weekly Executive Tactical Group, set up a YAS Quality Oversight Group that has representatives from, again, across the region, but we go into individual detail of incidents if required, check on duty of candour, and then look at what we can do to share learning across the system and indeed across the region. Emphasis is being on actions that has been taken and mitigations of risks, and these continue. Thanks.
Hello, I'm Brendan Brown. I'm the Chief Executive at Calderdale and Huddersfield Foundation Trust. And actually, I think the inquiry was related specifically from GPs in my area. And the two queries were, what would we do if our GP colleagues needed to discuss immediately with the emergency department staff to put them on standby for a critically unwell patient, or if GP colleagues needed to discuss immediately with our ED department if they were redirecting a critically unwell patient inbound and they need to direct family and friends. What we've worked through in conjunction with Carol as a place-based lead is a system whereby our GP colleagues can contact the senior clinical person for the hospital 24/7. Now, there was a bit of concern around accessing that through switchboard, so what we've enabled is our clinical site commanders to have a direct line which has been issued to our GP colleagues. We're also in the process of issuing a phone directly for our ED consultants so that there can be that direct dialogue. That's taking a bit of just working through around some of the clinical implications of that. But in the meantime, GP colleagues can contact an ED consultant 24/7 through our switchboard. So I'm hoping it's been dealt with. I think the office still stands for GP colleagues. If they want to speak to me in my place for Calderdale or Kirklees, or indeed any of the other chief executives or chief operating officers, if this hasn't quite been resolved, then we'll be happy to speak to them.
Thank you. Rob.
So I think there are a number of other sort of detailed questions with numbers in which Jenny's asked, which we'll respond to in writing, obviously. And above and beyond what Brendan's described, there's a further piece of work going on through the ambulance service and ourselves around what a more sustainable solution might be right across West Yorkshire and beyond for GPs who need to contact ED in crisis.
Thank you. And then our last question today is from John Puntis on new major condition strategy. Laura, you're going to give a summary of that and then we'll hand to Rob.
Thank you. Yes, I will. So in summary, the question is, the Chief Executive's report mentions a new major condition strategy from government that replaces individual disease-specific work. This aims to shape care policy for the growing number of people with multiple long-term conditions. There has been a massive increase in demand for mental health services for a host of reasons, and services are struggling to cope. Children and young people are less likely to experience chronic ill health, yet are the most likely to benefit from early action to protect their mental health. Does the board accept that this new strategy may pose a real risk of children's mental health being further neglected as parity of esteem between mental and physical health becomes even more elusive? And if so, what is it planning to do to mitigate this?
Well, it's difficult to answer the question because the strategy is not being published. I think there's, personally, I think there's two schools of thought here. You either see the whole person have a strategy which tries to do that, which I think is the intent with this new strategy, or you have individual strategies focused on specific areas. My hope is that within that new strategy, we see the whole person and their mental, physical and social needs are all addressed. Naturally, whenever these sorts of changes occur, there's always a risk that that won't be the case. To mitigate that, I think all of our work is driven through joint strategic needs assessments, which are built from places and are informed by insights from citizens and families. So we have a statutory duty, and we have a desire to make sure that we're addressing the needs of local citizens. That means that our children, our families, the focus on those will be a priority, and it's a priority in our strategy. So I think whatever the national strategy is, we will continue to address the needs of local children, and that's a priority in our new strategy.
Thank you very much. Okay, those are all the public questions. If anyone submitted questions after our deadline of yesterday, we will still provide a response. And as I said earlier, we will publish on our website the questions in full and our response, and respond to those members of the public. And again, thank you very much for taking the time to share questions with us. Our next meeting is in May, and we'll publish the deadline for that shortly. Okay, we're going to move on now to our governance oversight assurance section. You have my chair's report. As you know, my report aims to evidence the good governance work that we're doing at this time. It complements the strategic planning activities. One thing I wanted to highlight, which I did reference earlier, which was around the West Yorkshire Voice Forum. Really grateful to colleagues in communications and working community engagement, and our colleagues in Health Watch and across the voluntary community sector on helping us get West Yorkshire Voice off the ground. And particularly, this has been something we've worked with Health Watch for a good number of months now. And anyone watching online, either live or on record, I really encourage you to get involved with West Yorkshire Voice. It's a forum that we as a board want to connect strongly with, report back, have a conversation with, as well as draw in to provide lived experience and views. And that's how we will connect our engagement sessions in going forward. So West Yorkshire Voice launched on the 1st of March. I particularly took on board some feedback from colleagues in NHS Foundation Trusts, as this is an opportunity to include governors, and I've written out to all those foundation trusts to invite the governors to be involved as well. But it is for everyone, and please promote it far and wide. The rest of my report shares different ways in which we're working as a board, including our development sessions, plans for future focus on sessions, reflection on capital priorities, which other colleagues will talk about today. But hopefully that's helpful for us as a record of the work that we're doing together in terms of governance. I don't know if any colleagues have got any questions. Fatima, would you introduce yourself?
Good afternoon, everyone. Good morning, sorry. I'm a couple of hours ahead of everyone, obviously. My name's Fatima Khanshah. I'm proud to be the chair of the Race Equality Network here in West Yorkshire's Health and Care Partnership. I just wanted to extend the thanks from the Race Equality Network for your letter that was circulated on behalf of yourself and the chair of our partnership board, Councillor Swift. It really recognises the importance that we as a partnership have on our agenda of race equality, and the importance of demonstrating impact to our grassroots communities of the change that we're trying to instigate here in West Yorkshire. The network wanted me to extend my thanks for that. My other reflection was about the importance of the recognition of carers within the Voice Forum, and the real importance of recognising that there are sometimes barriers to people being parts of forums like this because of the timings, and also the need for remuneration or care cover. And it's really wonderful to see the hard work of colleagues in the communications and engagement team who've done some really great work on this to ensure that we're not creating unintentional barriers for our communities to really shape these important conversations.
Thank you, Fatima. And it gives me the opportunity to remind everybody to adopt our inclusive recruitment toolkit, which we support as a partnership across our health and care system. Thank you. Harris, would you introduce yourself?
I'm Harris Sultan. on the Next Director scheme on the ICB. My question is on the climate change part. It's great we've got a climate change strategy for the partnership now, but I think it's really important to think about how we embed this throughout the decisions made on the ICB, such as, is this a decision that our grandparents would approve of, that our children will thank us for? And also, how are we going to ensure that every decision we make moves us towards our obligation to be net carbon zero, as well as we've got these fantastic capital appeals on, but how do we go towards our legal duty of improving biodiversity within the area?
Thank you, Harris. Now, we do have two champions on the board for climate change, so I'm going to look over to Ian Holmes as our executive lead for that, and just giving him time to prepare an answer. You can look onto the Partnership Board website, where we have our climate change strategy that was signed off on the 7th of March, and what the whole partnership across health and care, and that's including our colleagues in local authorities, found very helpful, is there was a really helpful list on what you can do as a leader, what you can do as an organisation, and what you can do as a system, as a partner. And I think it's a great blueprint for us to follow. So, Ian, would you introduce yourself? Thanks for the question, Harris.
Yes, thanks, Harris, and thanks, Cathy. My name's Ian Holmes. I'm Director of Strategy and Partnerships for the ICB. And Cathy, you've slightly stole my thunder there, because I think you've answered the question. So I think the really helpful thing about the climate strategy that's published on our website is that we've got a really tangible and specific route map, or potential actions we could take as organisations that have been developed by the experts across the system. And I think there's then a question for us and a choice for us about how we adopt those, and which ones of these we want to adopt and which ones we really want to push forward in the next phase. The work that we're doing as part of the Joint Forward Plan, so it will be a Joint Forward Plan for the ICB, we'll describe that and we'll include that as part of that information. So that's how we're planning on ensuring that we'll get those specifics into our day-to-day work.
Thank you. And Becky, you have the non-exec remit in this area.
Yeah, thank you, Cathy. Thanks, Ian. Thanks, Harris. I was going to bring it up in the forward plan moment, but I think it is an opportunity for us to lead by example. So how do we audit these meetings? So when we talk about being a global leader for carbon zero and for climate change, that would include how we use our own cars, how we get ourselves to where our meetings are held, etc. And we haven't quite got that right yet, Cathy. So I think knowing how we are going to audit the work of the ICB and the board itself in relation to climate change would be really helpful, and it'd be helpful to be reporting on that and to know the vehicle through which we're going to report on that, please.
Okay, thank you. I think there's a few things that there. One is, as you all know, board colleagues, we are going through our first annual review of governance arrangements, but it's more than that. It's about how we work together as a board, how we're performing, how we contribute. So I think we can include it partly in that. I think there's then something, Becky and Ian, for you with the non-exec and the executive remits in working together. And then thank you, Ian, for talking through how that can be brought into our planning and work. But there is something about prompts and discussions and having that in mind and going forward. So Harris, I think it's work in progress, and I think we've gone from a strategy at the beginning of the month to now thinking about how we take the responsibility further in this board and this partnership. Okay, any other questions? Hannah?
Thanks. I'm Hannah Davis. I'm Chief Executive at Health Watch Leeds, and I'm here on behalf of the 6 local health watchers working in West Yorkshire. I just wanted to build on what you'd said around the voice element and West Yorkshire Voice, Cathy, and just to say I think it's really positive that we had 4 questions from the public at the beginning there. That that should be an indicator of how open the ICB is, and actually the ambition around putting these people's voices central to our work, but also being accountable to the people of West Yorkshire as well is really important. And I suppose I would just echo your message about getting involved with West Yorkshire Voice. It's not the only way. There's lots of different ways that people can be involved. And just to say, the West Yorkshire Voice is not a new network. It's going to build on all the work that's happening in local places, so really bringing and elevating those voices together. But just on the Agenda Forward plan, we've got some really important issues that we want to discuss as an ICB. Mental health, social care, dentistry is coming up on the agenda. So I just really encourage people to be part of those discussions going forward.
Thank you very much, Hannah. Any other questions? No? Okay. And just to note as well, we undertook our most recent briefing for MPs across the whole of West Yorkshire on the 10th of March, and a number of colleagues around the table were involved in that. Thank you for coming along. I think the MPs who come along very much value it, and then we do a briefing afterwards as well to follow up on a variety of things, service provision and capital priorities. So I will leave it there. I'm sure we'll come on to capital priorities again later. I'm going to move us on now to our next item, which is our Chief Exec's report, item 6. So Rob, over to you to give us an overview.
Thanks, Chair. So people have got the report, so I won't labour it. I would want to emphasise a couple of things and just to give a couple of updates, if that's okay. So I think first thing to reflect is that we're very fortunate, some of us in this room, to be part of the award of our certification last week for Partnership of Sanctuary. So we're the first ICB to be a Partnership of Sanctuary in the country. And it was a real privilege to listen to the lived experience of some refugees who live locally, who are involved in the sanctuary movement for some of the institutions that make up our partnership, including, for example, the Artworks in Wakefield, which is just up the road. I think that is part of our demonstration of the way that we support people who are vulnerable and are more likely to face trauma and the impact upon them and their lives. I'd like to thank Paula Sheriff for all the work and her team that went into that certification, and to Robin, who's not here, and James and Sahil for their leadership as well. We know that people who are refugees, asylum seekers, or have been trafficked, more likely to face trauma and adversity, and therefore more likely to become unwell. And the other thing just to draw the board's attention to is the 3-day knowledge exchange, which starts today, which is a national event that we host here in West Yorkshire. It's virtual, and we do get people from across the country coming to that. This is the 3rd knowledge exchange, and that's based on us being a trauma-informed system, another part of our strategy currently and for the future. That's an opportunity to share good practice, talk about issues and barriers, and network for what is a significant movement as we try to become trauma-informed across our whole system by 2030. So I wanted to draw the board's attention to that. I also thought it'd be important to draw the board's attention to the fact that it's World Down Syndrome Day today. James Thomas is the board director for Down Syndrome. That's a requirement of the Down Syndrome Act. And people and families, including my own, will be celebrating across the country all the beautiful and brilliant people who we live with. In my report, you'll see there's a reference to some of the work that we've done in the partnership around learning disability on the back of all of the evidence around inequalities faced by people with learning disability, inequalities of experience during COVID, etc. The team in the Mental Health, Learning Disability and Autism programme, working across the system, have produced a range of materials which help professionals and the public in terms of children, young people, growing up and growing older, and older adults with learning disabilities, and how they can be supported to fulfil their potential. So I point people to that on today particularly. In fairly positive news around industrial action, we've seen the proposal of, to the membership of a number of unions, a deal that's been struck between staff side and the government to potentially end industrial action for unions working under Agenda for Change. That we hope will be successful, because we know that the impact of industrial action on planned care particularly has been significant, which, whilst we keep services safe, will have been frustrating, anxiety-inducing, difficult for people and for staff. You know, if you've had to cancel somebody's operation again, you know, had to talk to the family again, these are not things that you want to be doing, and these aren't things which are risk-free for you as an individual. So that portion of the industrial action potentially be good news. Let's see what happens when the unions ballot their members, whether they're to accept the offers or not. Industrial action for junior doctors, 3 days of which took place last week, did have a substantial material impact upon services. It was managed through the effective working of people in this room and their teams. And thank you to everybody for that. We hope that there'll be some movement between the BMA and the government soon. And I know that our representative bodies, such as the NHS Confederation, NHS providers, etc., encouraging the government and the unions to come together to reach an agreement around that. As I've said in my report, those have been factors which have played into additional stress and pressure and affected our performance on things like elective recovery. We have, as you can see from the reports, maintained reasonable progress on elective recovery, some pretty good progress on cancer recovery, and our urgent care system has been tested to its limit, I would say, over the winter. I think we should all thank everybody in all of our institutions, whether they're in the third sector, councils, the NHS, our communities, for all the work that they've done over that period. You'll see from my report there are references to the staff survey. So for the Integrated Care Board, our organisation, each of the directors and their directorates have a report which talks about their results and what that might mean for them, and as conducting some actions and investigations with their teams around what they should be doing next. Each of the places is doing the same, and there are some cross-cutting themes which we are addressing. For all of the institutions in the NHS who've got staff survey results, you'll see that referenced here, and there's some work going on through the People Board around that, and there's some specific focus on race. I'll let Kate talk about that for a minute. Do you want to say anything about the staff survey, Kate?
Thank you. Hi, I'm Kate Sims. I'm the Director of People for the ICB. So just to clarify for those who aren't familiar, the staff survey is mandated for NHS organisations. We haven't at this stage got an all-inclusive health and care staff survey, but I think the results that have been published very recently for all of our NHS organisations are really useful to see. Rob's report refers to the fact we have seen a drop in completion rates. So across West Yorkshire for all of our organisations, there's been a drop to 43.4%. So it's back to sort of 2020 figures. And that might be something just for us to have in mind for next year. All of our results show for all of the NHS providers in West Yorkshire we're on or around the median. So that means that out of that scores of 10 that we're hitting medium or above for all of our scores. But I just wanted to touch on 2 or 3 headlines, I think, which would be useful for the board to hear. In the area of diversity and inclusion, this is really testing. Do staff feel that they belong within their organisations? We again are on or above the median. We're 8.2 to 8.6 out of 10. For raising concerns, we show again that we are on or above, but that's at 6.2 to 7.1. So again, I think it's something we just need to look at. Recognition and reward. So this is if our staff, how much they feel that they are recognised and rewarded. Again, whilst we're again on or around the median, we have seen that go to 5.8 to 6.4. And there's a number of possible reasons. One of them might be that current position around pay and the industrial action that we've seen. I think just a couple of last things for me to point out for here. Flexible working we see is a real driver for retention, and our mental health and community trusts have tended to score higher on this than our acute hospitals, with that sort of higher end of 6.8 to 7.1, and I think that's an area certainly for the People Board to be looking at from a collective point of view. And I think 2 other areas that I'll be taking to the next People Board consideration is areas around burnout and morale, where again, whilst we are still on or around the median across the country, I think they're 2 areas to look out for. So just a few examples there. Thank you.
Thanks, Kate. So just a couple of other updates I thought it'd be useful to share from the report. So you'll see reference to the letters from the Chief Exec of the NHS apologising for the outcome of a tribunal into racial discrimination, which was followed up by a letter from the Chief Nurse and the Chief Midwife for NHS England to professionals to do the same. That tribunal involved some members of our staff who were witnesses on both sides of the case, and we've been intervening appropriately with the individuals. We've been looking at what issues there may or may not be for us as a partnership. And we've been supporting individuals who may have been affected by this, because if you've read the tribunal results and the case, you can see that it's fairly shocking. So we wrote to all staff in our race equality networks, through our race equality networks, to offer staff support and solidarity. And we've had follow-up meetings supported by Fatima with race equality networks to have a conversation about how does this feel now, and are we doing enough? So just want to say thank you to Fatima for helping to support that, but also to everybody in the system who's been involved. These points around staffing are pretty important all of the time, and have become a focus because of things like the Workforce Race Equality Standard, because of our ongoing work around race equity, and because of this tribunal. Pressures on staff in the ICB and in our partners come from a number of areas. We've heard about the significant pressure on services, which potentially brings moral hazard and moral injury to our staff, and that's why we have a range of support available through line management and specialist services. Change also brings stress and pressure for staff, and we're constantly trying to improve services and drive change, which is from the bottom up, and using them to embrace new ideas. But change sometimes comes from above, and you'll see in the report references to running cost allowances being cut by 30% over the next 2 years within the Integrated Care Board, and plans to make sure that we can meet that running cost allowance change and support staff through it. So I just wanted to give the board an update that we've been engaging with staff, having conversations in each of the places in the ICB team across West Yorkshire, and I've asked Tim Riley, and he's accepted to step out of his day job for 3 months and to lead a programme of work, including people from every place and every directorate, to look at what the operating model needs to look like if we have 30% fewer staff or costs available to us. So that work is happening. Tim's been writing out every Monday with progress for staff on how we're going. We've invited the Race Equality Networks to be part of that too, to make sure that we've got the right voices in the room. And people are being proactive and productive and constructive in the conversations, whilst also we're supporting people who are finding it difficult. Tim, I don't know if you want to say anything else over and above about that. Okay. So we live in interesting times, and things continue to be challenging for us. We can address that challenge by our collective compassionate leadership.
Thank you very much. Questions and comments? Richard, would you introduce yourself?
Yeah, thank you, Rob. I'm Richard Vautry, primary care member for the board. I just wanted to raise a couple of points. Firstly, about the staff survey, that obviously doesn't include primary care staff, which obviously makes a significant contribution to the work within our system and partnership. And I just wonder whether there is something we could do locally, recognising that it isn't part of the national system, to capture the staff morale issues and that relate to general practice, dentistry and other services that we have responsibility for, and whether consideration could be done for that for in future years. So we've got some comparable data that we could then sort of reflect on and take action on as necessary. And secondly as well, to recognise that our staff within, again, primary care and general practice in particular, have not been taking industrial action so with respect to nursing staff, and yet any national settlement relating to any pay uplift, we need to recognise that the resources needed to support any staff increase in pay within a primary care sector would need to be identified. So there may be some national solution relating to that. It may be left to local organisations, but I think we just need to bear that in mind so that those hard-working primary care staff are not disadvantaged for actually not taking action. And I think we need to recognise the work that they do as well in general practice and primary care generally. Yeah.
So on the former, I'll ask, Carol might come in or Kate. So the fuller review into the future of primary care, the stock take into primary care, recognise that the staff survey doesn't cover general practice and should. So there's a fuller board which is chaired by Carol and supported by Kate's team, which will be looking at that. I don't know if you want to say anything about progress on that, Carol.
Sorry, took me a while to work out how to put that on. Yeah, I think you're right. I think those conversations around the Fuller Board and developing neighbourhood working are obviously key to the work of the Fuller Board. I think on the specific point, Richard, about staff surveys in general practice, which I think is specifically general practice you were referring to, although arguably it could relate to primary care in its broadest sense. It might be a helpful conversation to pick up with the local representative committees. So I think we have a regular dialogue, don't we, with West Yorkshire LMC, and clearly to do something like that, we would want to do so with the agreement of, you know, the local medical committees, as it is their staff that we'd be talking about. So perhaps we could pick up that conversation through that route.
Thank you. And just to add to that, I'm aware, Carol, that there's quite a proactive workforce steering group that reports to the Fuller Board, and I think that's where we could very much take that conversation. I think it's a worthwhile piece to explore, so thank you. Yeah.
I might ask Jonathan to comment in a moment. So in terms of the pay settlement, on the one hand, if it's approved by individuals within unions, then that's a good thing. There's some lack of clarity around where the funding is going to come from at this point. So the settlement will have an impact on this year's resources and next year's too, whether that's how we reimburse people in primary care, pharmacies, or our hospitals and community services. So Jonathan, I don't know if you wanted to give an update on that.
Yeah, I'm not sure. Sorry, my name's Jonathan Webb, Director of Finance at the ICB. I'm not sure if there's a great deal else I can add to that, Rob. I think we know what's sort of been said in the national media across the weekend in terms of where the funding for the settlement may come from. So I think we just need to wait and see on that front. There is a bit of an issue around the extent to which those costs will hit this year's position or not, depending upon whether the offer is accepted or not, and we'll wait to receive NHS England guidance on that. I think we'll also need to look quite carefully about what if there is national funding available for ICSs and ICBs, what that means for both NHS providers as well as ICB staff, given the context of those running cost reductions that you referred to, Rob.
Thank you. A watching brief there, and we know our colleagues in NHS Confederation and NHS providers as well are doing their work on behalf of trusts and ICBs overall. We've got two questions, I think, one from Fatima and then Hannah.
A couple of reflections, if I may, Chair. The first is really important to acknowledge the staff survey, and particularly the findings from a workforce race equality standard perspective. It's very easy when you see numbers to forget that every single person that reports an experience of discrimination experiences trauma as a consequence of that, and we've seen and supported the reality of that recently in West Yorkshire. Our Race Equality Network really applauds the courage of these individuals that have come forward and shared their stories, and we're very grateful to you, Kate, and to you, Rob, and to Ian Holmes, our Strategy and Partnerships Director, for giving the time to come to the network and have a very open and honest and quite courageous conversation about the lived experience of colleagues here in West Yorkshire and some of the feeling that's happened as a consequence of the letters and correspondence that have come out recently. We really appreciate the focus on direct action. I think there is some real tiredness now about rhetoric, about how important this is and people's commitment. The time of rhetoric is over, the time of action is now, because people are suffering as a consequence of this. And I think one of the things that came out of the conversation we had was the importance of culturally competent support for staff. So we've got a really excellent hub. We're doing some work to make that hub very culturally competent, and supporting people with trauma requires cultural competence as well as trauma and adversity training. So we're really supporting that. The other thing, which I think is a really important commitment, is the work that Ian Holmes has led with Tim about ensuring that the Race Equality Network is represented in the conversations regarding change. We know that the data tells us when we are doing restructures, staff from ethnic minorities, or now the global majority, as we refer to them in West Yorkshire, are more often than not adversely impacted as a consequence. So we think that the work that we're doing, although challenging, is the right thing to do and demonstrates the courage and commitment of West Yorkshire on this agenda. So thank you to all of you.
Great, thank you. Hannah.
It was just to pick up on the point around the staff survey, and I think you mentioned it, Richard, but I didn't want it to get lost. At the last session, we had a workforce-focused session, and we definitely heard from social care staff, home care staff, care home staff. And I suppose it's not to miss that. We need to hear the whole voice from a health and care system.
Thank you, Hannah. That's really helpful. And if anyone watching online is interested, we can go back to that January report where Kate shared with us a great briefing and bedrock of information for us on our workforce. And as you know, as members of the board, we met a number of staff, including from social care, who shared the good things about working in social care as well as their frustrations as well. Okay, thank you. Rob, do you want to come back?
I just wanted to make sure that, you know, as the board of the ICB, the statutory body within a partnership, we should ask the people board underneath the partnership to make sure that it's taken account of these issues in the people plan, which is owned by the partnership board and the other partners as statutory organisations, the councils and then the charities. So it seems to me we've made a number of really important points about things that we think would benefit from the learning that we've got here, other sectors that the people board should take into account and we should see coming through the partnership board in the future.
Great. Okay, that's great. We can take that as an action, and that's how we weave and connect this board with our partnership as well. Okay, Kate, you're nodding, so that's good. Lovely. Thank you. Any other questions on Rob's Chief Exec's report? No? Rob, is there any final points?
Just wanted to confirm that we have yet to see the primary care access recovery plan or the long-term plan for the workforce.
Thank you. Could you give us a brief update on the Hewitt review, which is obviously directly related to system working?
Yes, I referenced in the report the Hewitt review, which is looking at the accountability and authority of integrated care systems and integrated care boards, undertaken by Patricia Hewitt, who chairs Norfolk and Waveney ICB and is a former Secretary of State for Health. So her report was due out in early March, but I think has been delayed until the end of March, while some further work takes place. I think it will be a real opportunity to reset how the system works. One of the things I'm always keen to do is to recognise that subsidiarity, our principle of subsidiarity, which we hold dear, goes all the way from the national system right through to an individual. So we want people to support themselves. If they need some support from us or to work with us, then they can do that in their home, in their neighbourhood, in their place in West Yorkshire. Excuse me, sometimes in Yorkshire and Humber, sometimes nationally. That requires us to really value at each level what institutions working at those levels do. So I think the Hewitt Review is an opportunity for us to think about the new NHS England, which brings together Health Education England, NHS Digital and NHS England as was, with a role around people and technology and process, interfacing with us as an integrated care system and an integrated care board. Those relationships could be really powerful in a context where we really need to be thinking about people and we really need to think about technology and we really need to think about process, because allocative and technical efficiencies and improvements in outcomes and personalisation are all things that we're going to have to get right. So I hope the Hewitt Review sets some of that out for us and also makes it much clearer the relationship that we'll have with the new NHS England in the future.
And thank you very much, Rob, for being part of the advisory group, the working group, working alongside Patricia Hewitt and other leaders across systems in the country. Okay, and we await that report. Okay, thank you. We're going to move on now to our board assurance framework. And then, colleagues, you can see in the agenda after we've had a discussion on that, we're then going to pause the meeting. We're then going to go into our engagement session, a lunch break, and then we're going to come back at 1 o'clock for the rest of our meeting. This is us trying out different formats in the ways of meeting as a board. So item 7 is our board assurance framework. Laura, is there anything you want to highlight? And then, colleagues, let me know if you've got any questions or comments.
Thank you. As board members will be aware, we have been working over a number of months towards producing a board assurance framework, or BAF as it is better known. At our last meeting, we approved the first phase of the BAF, which saw the population of the ICB core controls and assurances, and today the fully populated BAF with work completed by the 5 places is brought for approval. Now we have a fully developed BAF, the important work of starting to use it begins. So the BAF is designed to provide the ICB and its board with a method for the effective and focused management of our principal risks and assurances about how we meet our objectives. Used properly, it should be set in our agenda as a board, and it should be prompting discussions across our committees, both at West Yorkshire and place level. From a process point of view, you as the board will see the full BAF biannually, complemented by reviews of the action plan, and that action plan will detail all of the mitigating actions that are set out within the BAF and will help you to be able to maintain oversight that those are being implemented. You'll also see the heat map, which details the current and target score of each strategic risk, completed by both West Yorkshire Core and Place. To provide you with that assurance, each of the board's committees will review the BAF regularly and use it to inform their work. And committees might undertake, for example, deep dives into particular areas and will report that assurance back to you via the AAA reports. The Audit Committee will also play an important role in assuring this. I would just like to say thank you to Liz Allen, who has been absolutely instrumental in developing the BAF for us. That was all I wanted to say by way of introduction, but very happy to take questions. Thank you.
Okay, and the Board Assurance Framework, the BAF, has had a task and finish group of members of this board, Audit Yorkshire, and we've also had the Audit Chair from Yorkshire Ambulance Services, a co-opted member and a critical friend. Liz Allen has come in and done this great piece of work. I suppose this is the first example of how we've worked together, created something to, as a good governance tool. Task and finish group has now finished its task, and now we need to, as you say, test it in practice. Are there any questions or comments at all? Becky?
Thanks. This is great. I actually feel like I've got a sense of what's really going on, and no offence everybody for the last 6 months, but it's really good to see it set out like this. There's just a couple of things to note. One is that on page 44, which is our 1.3 around rationing, when you look at the place report, Tim, I think we've got a fairly congruent response from Leeds about the implicit rationing of waiting lists. I know we've talked about this at the board before, Rob, and I suppose it's at what point does being on a waiting list feel like it's just waiting, and at what point does it feel like it's rationing? I know you were clear, Rob, that we've always managed our demand through waiting lists, but there seemed to be some slight difference here between the way Leeds is talking about it and us saying as a board, we're not rationing anything and we don't think we're going to unless there's a major financial disaster next year. Whereas there is, I think, a nuance around actually people's experience of waiting can feel and does feel occasionally like rationing. And I want to obviously take us back to our neurodiversity waiting list, which can, for some people, be incredibly long. And that does feel like rationing. So firstly, I think there's some congruence there about our response and our understanding of that. That was the first point. And the second one is around 55, 3.4, and it's about how we're taking on primary care. And I suppose it's knitting it, Carol, much more into our approach to Fuller. So Fuller Stocktake has this, I guess, a more integrated approach to the development of primary care that really addresses both urgent need or immediate need for appointments with people's ongoing need for chronic care coordination and management. And actually, if we look at the patient satisfaction surveys around primary care, people are satisfied when their needs are met, and I think it's got lost in the national interpretation that people are satisfied when they get an appointment on the day, and that isn't what the survey says. So when we're thinking about how we organise care, if we take Fuller in its full, which is how do we manage transactional and urgent care, and then how do we manage people who have complex needs through a more continuity model that gives them some consistency and meets their needs, then people don't turn up as frequently, they don't need as many appointments. And so how we measure that, that's partly about how we're going to look in our own integrated dashboard about how we measure primary care. But I think our response in the BAF needs to reflect our collective West Yorkshire response to this, not just taking, I suppose, a national narrative that can advance us into a transactional model that would increase demand without meeting need. So it was just if we can perhaps reflect that in that. So both of those would be helpful. Thank you.
Okay, thank you, Becky. So an area around waiting lists in general, but then specifics and then primary care activity. Rob?
So on the waiting front, Brendan and Jonathan might want to come in as well. I mean, because those of you watching or those not aware, the West Yorkshire Association of Acute Trusts is taking forward the elective recovery programme on everyone's behalf. And we also need to think about why you might ration, which to me suggests often that you do that for financial reasons. Now, at the moment, we're planning for next year. We might come on to this later. And I think in my career, there's certainly been times when people have thought about, should we slow down activity because we can't afford the activity that we're delivering at the moment? And it is possible to achieve national standards and slow down activity to save money, which I think is a form of rationing. And what we'll get into, I think, at some point, when we're getting into, is there a gap in our financial plan? Is that one of the actions we want to take? And I would want to see that reflected in the board assurance framework. So on the waiting front, I think that's when we'd get into a rationing type conversation. Are we rationing because of money? And at the moment, I think we tend to have access problems because of capacity and the availability of the workforce, rather than because we want to save money. So that's what I wanted to say on that. I don't know if Brendan or Jonathan have any comments on that as well.
No, I think you've covered it, Rob. Rationing isn't a language any of us would want to use because there's an impact for patients. I think West Yorkshire, certainly from an acute perspective, but equally in other sectors, is doing well because we're doing the right thing for our patients and their families. If there's a conversation about national monies impacting on our ability to deliver care for patients, that's something that we'll have to discuss here. It would be something I would imagine our colleagues would be very uncomfortable with, but it might be the state of the nation conversation that we need to have. But I think we need to keep in mind that actually we've continued to perform better than others because we've had a focus on patients and their families, and we'll continue to do that.
Thanks. Just to add that to probably sort of 3 points really. I guess one is around almost sort of looking at service transformation to sometimes sort of manage those patients in a different way, which might be sort of the effectiveness bit, I suppose, which I think all places are looking to an extent. There's certainly no conversation around rationing within the finance, within the DOF community, in terms of the conversations we've had as part of planning. What we are talking about is how we can do things more efficiently. So whether it's about day case rates or theatre utilisation. So there's lots of work on that regard. I guess the final thing to say is that just picking up Brendan's point around sort of national incentives around money, we are continuing to explore with NHS England to put in a different approach to how that might work for next year for West Yorkshire, which is based more about patient outcome rather than just churning through numbers, which isn't necessarily the right thing to do.
Primary care.
Yeah, I really like Becky's reflections on primary care because they do two things. I think on the fuller stock take and its implementation, people often alight on it's about multidisciplinary teams and ignore some of the other fuller elements which are about that stratification of patients. You need a different response from someone who just needs same-day urgent care than somebody who you've got a relationship with on an ongoing basis. And we've got to measure the things that will tell us whether we're succeeding or not in our strategy. So I think it's a really good reminder that those two things are incredibly important. I don't know if Carol wants to say anything or Ian.
Yeah, I agree with that, Rob. We had a really good conversation actually at the last fuller board with Carol and Richard on this exact point. How do you measure effective integration? How do you know if you're making a difference? What are the ways that allow us to tell that the work that we're doing is going at the right place? So that's going to be a sort of a key priority for the fuller board going forward. I think there maybe is something under this, the way we've described the kind of the source of assurance around 1.4 that feels a little bit less transactional, a little bit more about how do we build evidence of patient experience of integrated services, so we can amend that for that. I think it's a really helpful point.
Okay, and we'll get onto this later, but I'm grateful to colleagues who've volunteered to put some time into looking at our integrated performance report, which will give better insight. That's what we're looking at across our whole system, including you, Becky. I'm very conscious of time because we have colleagues from the voluntary and community and social enterprise sector waiting for us for an engagement session. But Rachel and Hannah, I know you've got comments, and perhaps we could take those, aim to answer them quickly, or we'll pick them up in the next half of the meeting. So Rachel, would you like to go first?
Yes, thank you, and I will be brief. It was just to say, I think looking at Rob's Chief Executive's report and the kind of reduction in running costs, we need to understand how that destabilisation will potentially impact on this, because as articulated, you know, the anxiety, etc., it does sometimes have an impact on productivity and therefore what we're trying to achieve. So I think just thinking of this assurance framework with that in mind is going to be really important in the next few months. And I just want to echo Becky, really. It's been really useful to read all this, and I think looking at those mitigating actions and understanding how we can see best practice is going to be really valuable for each of our places. And I think how we use this then to prioritise the board's work, I think we need to think about how we pick that up in the governance review, because I think that would be really helpful going forward. So it was just an observation rather than a question.
That's great. Thank you, Rachel. We've achieved what we wanted. Hannah?
Pretty much what Rachel said, actually. But I suppose just to say, I agree, it feels like a really important document, but actually more than just a document, because this is what we want to achieve. This is the vision, isn't it? These are all the elements. And I suppose it's how we stay true to that at a very challenging time, and how that informs all the decision-making, both at West Yorkshire and in local places, in things like finance and all the things that we know, those tricky decisions that we've got to take.
Thank you. I also want to compliment everyone who's worked on this, because what we're trying to do is include places. It was a decision we made together in Leeds in June last year that we wanted our board assurance framework to work not only at system level but for places, and that created the connectivity as well as the subsidiarity that we wanted to achieve. There are other board assurance frameworks available in other regions across the north of England, but what I can see so far is they haven't included places. So I'm really grateful that we're kind of trying to work in this way, and as agreed, I think we all need to make a commitment to make sure this informs our work and our agenda setting. Becky, have you got a quick comment?
Yeah, it's just as we close this part of the meeting, which is that I work with a number of ICBs, and Rob, I think as a non-executive, to say thank you for how you're handling the transition into our new operating model with Tim and the way it's been handled with staff, because things are not, as a non-exec, I don't see the work slowing down whilst the team is handling some of that uncertainty, and I really must commend you all for that, because obviously it really matters to the people of West Yorkshire that the work doesn't slow down, but there is a real risk of that happening. And so thank you for the work you've been doing, and thank you for the webinars you've provided to staff. I certainly, as an observer, appreciate that. Thank you.
Thank you. So I'm asking you as a board to sign this off as a board assurance framework for us to use and test together. I think, Hannah, you put it well. It's a live document. It's for us to use. So are you all happy to sign it off and commit to testing it? Great. Thank you. What an achievement. That's really good. What I also want to remind you of is that when we got together in August last year, we agreed that our risk appetite could be adverse, it could be cautious, it could be open, it could be bold. And I think we must remember those things as well in holding each other to account and working together. So thank you, colleagues, for that great first discussion. We've had a lot of things, a continued commitment around involving local people in decision making, a discussion briefly on climate change, a watching brief on excess deaths, taking a variety of public questions which we'll commit to provide public responses to, a discussion on greater inclusion on primary care, and greater insight into focusing on local people's care and remembering that we're here to serve every resident of West Yorkshire, and a continued commitment on equality, diversity and inclusion as well. So thank you. That was great. That's just the first bit. We're going to take a break now to go and meet some colleagues from voluntary and community and social enterprise sector, and then we're going to start again at 1 o'clock to then have our focus on topics. So thank you to anyone who's been watching live online, and we're aiming today to give some more social media content as well to talk about the board meeting. Thank you.